A quick update before we start this podcast. We often batch record the podcast. We have to fit them in around Pete's modelling career, so we record them where we can. So it's been a while since we recorded this one. People call me the mailman because I always deliver. But after this episode, they're going to start calling me Nostradamus because I predict the future. Since we recorded this episode, Bryan Kelly has gone to become President, CEO, and Surgeon-In-Chief Emeritus of the Hospital for Special Surgery in New York. Check it out. I think you're going to like this one.
Go, clapper goes. Hi everyone, welcome to the latest edition of the Author Hub C1D1 podcast. Pete, what are we talking about today?
There's a couple of things going on today. First, it's about being at the forefront of a new type of surgery. You know, when you're one of those pioneers, one of those early adopters, developing new techniques and everything that goes with that. And it's also about leadership. We're talking with someone who's we've all been on, like, a lot of us have been on leadership courses where you learn like some things, some do's and don'ts, and different techniques of leadership and how to get people back on board. But I think this is another level up. This is more about taking on a big institution with a big pedigree, a huge expectation, an internationally renowned institution where there's great visibility, but there's a lot of expectation upon you. And how do you handle your inner imposter phenomenon? How do you handle all those big personalities around you? And some of whom are obviously going to be very senior to you. So in short, it's about holding the post of Surgeon-In-Chief at HSS, Hospital for Special Surgery in New York.
Great. Just to stop you there, though, I don't think imposter syndrome exists in America.
It's not allowed to.
We'll come back to that.
We'll come back to that.
So listen, our special guest today is Dr. Bryan T. Kelly. I'm not sure what the T stands for. My bet is on Tiberius, like Captain Kirk in Star Trek.
No, it's not. It's Tom.
What's the T for?
Terry?
Well, it's a family name. It's probably not one that you've heard of before. It's Talmadge, Talmadge.
We could have
and
guessed.
It's after my great grandfather, who was a oyster boat fisherman off the coast of Baltimore. His name was Captain Talmadge Mister. So I come from a line of Misters.
Wow.
And Talmadges are running the family.
We could have guessed for 100 years and we wouldn't have got that.
I don't think you would have got it. So my dad's middle name is Talmadge, after his grandfather, and mine is Talmadge, and my oldest son Connor's middle name is Talmadge. So we're trying to revive the name, get it a little bit more popularized.
Yeah,
love it. I think Tiberius was closer than Tom.
Tiberius would be better, maybe better.
No, I'm loving the history. So Dr. Bryan Kelly, aka BK, aka Mr Hip Arthroscopy, aka Mr New York. He undertook his undergraduate studies at Brown University, Providence, Rhode Island, and medical school at Duke University School of Medicine in Durham, North Carolina. Go Blue Devils. He did his internship at the New York Presbyterian, and then residency at HSS, the Hospital for Special Surgery in New York. After he completed his residency in 2001, he did a 2-year fellowship at HSS, specializing in sports medicine and shoulder surgery, and then a fellowship in hip sports injuries and arthroscopy with Mark Philippon in Pittsburgh, which we're going to come back to. Prior to starting his practice, he also completed an AO International Traveling Fellowship, where he spent some time in Austria, as well as with Professor Reinhold Ganz, who's world famous, in Bern, Switzerland, studying advanced techniques in open management of hip and shoulder injuries. He's authored over 140 scientific publications, and some of the highlight awards include the Charles Neer Award for Excellence in Shoulder Research, which in that sphere is a big deal. It wouldn't mean anything to you. It's a big deal.
What do you mean it wouldn't mean anything to me?
Well, you just do maximally invasive surgery. The Philip D. Wilson Award for Excellence in Orthopaedic Surgery Research, the Lewis Clark Wagner Award, the Jean C. McDaniel Resident Teaching Award, the Nancy Kane Bissoff Award, the AOSSM Excellence in Research Award, and the AOSSM Herodicus Award. He is Chief Emeritus of the Sports Medicine Institute and was co-director for the Center for Hip Preservation at HSS, and he is the Surgeon-In-Chief, a medical director at Hospital Special Surgery, and a professor of orthopedic surgery at New York's Weill Cornell Medical College. Almost there. He specializes in sports medicine injuries and the arthroscopic and open surgical management of non-arthritic disorders around the hip. He cares for several sports teams and is a head team physician for the New York Rangers, associate team physician for the Giants, also the New York Red Bulls MLS team, several collegiate teams, and he is the orthopedic consultant for the UFC, the Ultimate Fighting Championship.
Okay.
So I'm hoping he can get us an invite to Vegas. So, Bryan, welcome to Author Hub.
Thanks. It's a pleasure being here.
to thank my dear friend Daniel Nawabi, aka the Golden Boy, aka the Prince of Dubai, aka the Chosen One, for connecting us. I think he was really wary at first. He was kind of weighing up like, how badly could these jokers impact my career with the boss? So we'll do our best. So just behave yourself.
Yeah, well, let's try not to get Daniel fired.
Yeah.
Brian, can you kick us off? Tell us about some early years. What were you a medical family? Your dad wasn't an oyster fisherman, presumably.
No, my dad was not an oyster fisherman, but I grew up in Connecticut, and I have one brother, and the four of us, really, neither my brother nor myself had any interest in going to medicine. When I went to Brown University for my undergrad, the two primary reasons I went there is because it didn't have a math requirement for calculus, so I didn't have to take math anymore.
The best reason.
And I was throwing the hammer. I was a hammer thrower in track and field, and like the coach at Brown. I had no interest in going into medicine. At Brown, I was my undergrad majors were in music and psychology, and then around my senior year, I got hurt. Or I guess my junior year, I got hurt throwing the hammer. So an extra year of eligibility, I decided to stay there for a fifth year. I started thinking about my future. I realized I wasn't going to have a career as a hammer thrower, and the way things were going, I was either going to be a psychologist or a third grade music teacher, because I realized I wasn't actually very talented in music either. So I started looking into medicine, and decided going to medicine would probably be a good idea at that point. But we grew up in a family. My dad was an oral maxillofacial surgeon, but really never pressured us, either my brother or myself, to go into medicine.
And your mum, what was her background?
So my mom was a systems analyst. She came out of college. Both my parents went to Brown, and my brother was at Brown, so we were a Brown family. And my mother came out, I guess they graduated somewhere around 1961, 62, and she worked for IBM. We sort of working for IBM when computers were starting to get up and running. She became a systems analyst for a couple of different companies, Pepperidge Farm for a while, and US, some news company. I never was clear what she was doing, to be quite honest with you. And
maybe she was a secret agent.
I think she was, actually. And she definitely has the personality for it. Nobody would have ever suspected her as being one.
And how did you end up at HSS?
Because I was delayed, I decided my fifth year in undergrad that I was going to go to medical school. And given that the reason I chose Brown was so I didn't have to take science classes or math classes, I was a little bit behind the eight ball. So I had to do all my pre-med stuff my fifth year, and then took another year off. Ended up at Duke for medical school. And that's when when I got to Duke, I didn't actually know what I wanted to do in medicine. I just thought it would be better than my current career trajectory in music and psychology. I actually think I went to medical school initially thinking I was going to become a psychiatrist.
Right.
And the year off between medical school and undergrad and medical school, I took a job, went back home, lived in Connecticut in Reading, and took a job in Danbury, Connecticut as a caseworker. They had recently deinstitutionalized one of the mental health facilities called Fairfield Hills Medical Facility. So there were a bunch of previous patients who were kind of trying to get integrated into society, and they had a variety of different mental health problems: schizophrenia, bipolar, alcohol, substance abuse, learning disabilities. And when I got there, I was like the 10th person. So there were 9 other people who were managing all these people, and everyone gave me one of their people. So everyone took one, gave it to me. And it became very clear that everyone took their absolute most challenging patient and gave it to me.
Dump on the
so
new
they
guy.
didn't have to deal with it anymore.
Yeah.
And so I spent the year working with a really very interesting year, dealing with some challenging socioeconomic issues with mental health. And it was a very interesting and rewarding year, but it became clear to me by the end of that I'm not going to be a psychiatrist. And I always loved sports, and realized that this was a potential career opportunity for me going to sports. By the time I got to Duke, I pretty much just saw myself as being a sports medicine orthopedic surgeon. At Duke, they do it a little bit differently. They do all the didactics in the first 18 months. You start your clinical rotations at year 1.5. And they have a 9-month period where you do research. And so the research was it was a great opportunity because when you're applying for residency, having some research productivity is good for the application. So I get connected with a shoulder surgeon at the time, Dr. Kevin Spear, who had been a fellow at Hospital for Special Surgery and had done his residency at Duke University. And he was one of the most productive researchers. I spent the year with him and really started to get enamored with shoulder surgery and with sports medicine. And he was my connection to Hospital for Special Surgery. So he was very supportive of me as a medical student, and was really instrumental in my choice to come to HSS.
And did he write you a letter? Because the letter is like the golden ticket, isn't it, in American medical schools?
He wrote me a letter for sure.
Yeah, the reference, but it's like that's the golden ticket that makes it.
Yeah.
So going back to the psychiatry thing, do you feel like that you've got this kind of, accepting that you gave it up and you realised that wasn't your number one choice, nonetheless, you've obviously got an affinity for it. Do you feel like you've got like a sort of residual affinity for understanding people with mental health problems, and it's one of your sort of secret superpowers that perhaps other orthopods don't have?
And it's great training for being Surgeon-In-Chief, right?
Yeah, right.
Well, I'm telling you, I think I can tell you the questioning is leading me down a certain path. Dealing with a bunch of crazy doctors. And,
I never said anything like that.
I could read you a mile away. I will be honest. We have the Hospital for Special Surgery is an incredible institution, and I did all my training here. I was a medical student in 1995 and met some of the people who are still here as my mentors, and spent 5 years of residency, 2 years of fellowship, went away for 1 year to UPMC, and then came back, started my practice in 2003. So I've been at this institution since 1995, pretty much straight, with the exception of a short period of time in Pittsburgh. And it's just a really, really incredibly unique institution. There's a lot of just super successful doctors and surgeons here that are really, really highly motivated. And we're in the middle of New York City, which is a bit of a pressure cooker to begin with. And everyone's, competing against one another. And the way that the business of orthopedics is at HSS is that everyone's sort of in private practice for themselves. We have about 140 solo practitioners who are competing against each other for the same patient population. And and everyone seems to be able to make it, but there's a lot of stress associated with that type of environment. And I think the ability to try to navigate that and try to understand where people are coming from, and with a really, really highly successful, intelligent people, I probably should have gotten a PhD in psychology, not just spent a year, but I think there's probably something about it that helps for sure.
Yeah. But that leads nicely on to the next question, which is, you've been there, man and boy, and now you're the boss. Have you ever worried about, not having a broader outlook, becoming a little bit institutionalized, or being a bit narrow focused, say, or being potentially criticized for that? I mean, what are your thoughts on that?
I would say that was one of the primary reasons I went to Pittsburgh for the year.
Right.
Was to get away and see a different institution, different way things work differently. I think there's pluses and minuses to it. I think there's a culture to HSS that it's very difficult. There's a lot of people now that will come in who've had a practice elsewhere and come in, and they're just like, it's a little bit of a culture shock when they get it. Yeah. It's like, this is how you guys do it? I'm like, isn't that normal? I mean, that's just the way you do it. So I think there's having the recognition that there's something unique about this institution, having is really critical. Having a perspective on what it's like elsewhere is really very, very helpful. I think one of the things that happens in orthopedics, particularly if you're involved in different subspecialty fields, you get the opportunity to meet lots of different places from other institutions. And so I have a good circle of colleagues and friends in different locations, both in the United States and as well as in Europe. And I spent a lot of time talking to them about, well, what's it like at your institution? I think it clearly is better to actually have been integrated into other institutions, so you really feel it. I would say if you're looking at the risk benefit, I think understanding the culture and being here is really critical to anybody's success because of its uniqueness. But I think making sure you're understanding the perspective in the broader context is also very important.
The thing is, whatever the special sauce is, it works. Despite all that competition, as you say, and I spent a month there, 2014, as part of my Winston Churchill Fellowship. I was visiting Anna Ranawat and Bob Marks, and they're great guys. And every time I'd walk down Manhattan, Upper East Side, there'd be flags flying saying rated #1 for orthopedics. They'd be on flying off street lamps. And it's been #1 in the US for orthopedics for like 10 years in a row or something now.
It was 13.
13. I'm behind the times. And so whatever it is, it clearly does work.
Yeah. Yeah, but it's just interesting, isn't it? You talk about special sauce because just recently we did a similar podcast with a guy called Sanj Kakar, who's at the Mayo Clinic, and they again score incredibly highly, and yet their business model or the model of payment is salaried doctors, no competition no internal competition.
It's completely opposite. When we look at different business models, I think HSS is on one end of this spectrum and Mayo's on the other.
Yeah.
And it's interesting. I think the thing that both Mayo and HS have in common is you start with high quality individuals.
Yeah.
There may be some nuances as to how they are able to be successful in different environments, but I think the common denominator is who the individuals are.
Yep.
The other thing that was quite interesting for me was that I basically went from HSS to Parkland in Texas,
right? And
the patients tripled in size overnight. That was quite astonishing. You've mentioned UPMC, your fellowship with Mark Philippon. I want to ask you about hip arthroscopy because it's still, ironically, considered, in certain places, it's still relatively new. I was in 2010 as a resident, and I was assisting a boss who was doing his 3rd, 4th, and 5th hip arthroscopy.
Oh, man.
All on the same patient, all on the same hip. Don't ask. That's a story for another day. And literally we had 4 hours of patient on traction with a red screen, and it was painful. So when you went there, hip arthroscopy was really, really right at the beginning, wasn't it? So where was it at that time?
So I'll tell you. So when I was a resident and a fellow, so I was at HSS for 7 years, and one of the things that HSS is known for as a residency and fellowship program is the volume of surgery that you do. You just do. There's a lot of surgery going on, so you're in the OR a lot. And I really did love pretty much every surgery that I did. I did 2 hip arthroscopies in 7 years. And after I walked out of the second one, I remember as if it was yesterday saying to myself, that was the worst operation I've ever experienced in my entire life.
Yep.
I would never incorporate that into my practice. It was awful.
Yeah.
I'm like, I don't know. It took 4 hours and I don't think I ever saw the femoral head.
Yeah, just a red screen.
The entire time. So that was sort of my initial. And my plan was to be a shoulder surgeon. And Kevin Spear was my connection to HSS from the beginning. He was a shoulder surgeon. I was very interested in. I'd done a lot of shoulder research. No interest in hips at all. And so when I was the beginning of my 2nd year of my fellowship, Dr. Warren, who was the Surgeon-In-Chief at the time, and I was the fellow helping out with the New York Giants at the time, offered me a job. He said, we'd love to have you come back, and maybe you can help out with the Giants a little bit. And I remember thinking that'd be great. I think there were about 20 to 22 sports doctors at the institution by then.
Wow.
But I'm going to be the 23rd surgeon doing ACLs and shoulder instability and rotator cuffs. Like, it's going to be hard it's going to be challenging to do that. And one of my chief residents when I was a 2nd year, named Dr. Dave Levine, had done a foot and ankle fellowship after his residency, and he came back and he was crushing it. He was just doing all the surgery, and I remember running him to the hall, and I said, like, how are you doing so well? I mean, you just started here. It's such a competitive environment. He said, Brian, this is the best place in the world to do orthopedics. Well, if you ever stayed here, just make sure you're doing something different, because you don't want to do what everyone else is doing. So this is the place where you need to subspecialize. So I was sitting there, I was thinking about that comment. I was so happy. I was at a job, it's my dream job. I'm going to be a sports doctor in New York City, helping out Dr. Warren with the New York Giants. And I was sitting there reading JBJS over the Christmas holidays. And for me at the time, reading JBJS was going straight to the back and looking for job opportunities. I never actually read the articles because they were like, I'm like, oh God, talk about another reason why, there's osteolysis during cemented total knees. I'm like, so
or
I was reading
the
job
femoral
things.
tunnel, right? Or the ACL.
Yeah,
Another one.
exactly. What should it be at 10:30 or 10 o'clock or
Yeah.
9:15? I'm like,
Exactly.
so I look at it and there was this thing, UPMC, sports medicine and hip injuries, Dr. Mark Philippon. I'm like, you know what? I should probably do that because there's got to be something to do it. I looked at UPMC for medical school and for residency and was always impressed with it. I thought it was an incredible institution. I thought Freddie Fu was amazing. So I said, well, maybe I'll just do that for a year. So I go back to Dr. Warren. I said, Dr. Warren, I'm so honored and so privileged to have this opportunity. I was just thinking I should probably do a little additional training before I start so I can bring something new to the institution. He goes, that's a great idea. What are you thinking? I said, so I was thinking about the hip injuries, hip sports, hip arthroscopy. He goes, that's great. He said, instead of starting in August, you can start in September. I said, well, actually, it's a year. It's a year-long fellowship. He looks at me and goes, are you out of your freaking mind? What are you going to learn? You need a year to learn how to do that? Are you going to waste a whole year doing that? Not for nothing. Who is this Mark Philippon guy? I've never even heard of him. And so walked out thinking, how am I going to get around this? And then over time, there's this thing with Dr. Warren that he thinks about it, and then eventually your idea can become his idea. And so he came back to me and said, you know what, I think you should do a year-long fellowship. I said, well, I'd already applied and accepted and we'd already rented a house. So I'm like, that's such a great idea. I'll look into it and see if it's possible. So I went to Pittsburgh, and Lois, my wife, was pregnant with our first son. And I remember she was not happy. She's like, what is wrong with you? Like we'd been dating throughout residency. We're about to have a kid. She's like, you're about to start making more than $45,000 a year. And we're going to do this for another year. And so, and even worse than that is I started the UPMC fellowship on a Friday. I didn't want to miss the first day. And I was operating at HSS on a Wednesday. So I sent my 9-month pregnant wife out to get the house set up for us while I operated all day long with Ainsworth Allen on a Wednesday. And it was like the best operative day because I'd known Ainsworth since I was a medical student. And so I must have done 6 cases and he would let me do everything skin to skin. And he was just sort of sitting there, we were talking. Then I drive myself to Pittsburgh, go to UPMC on Friday for my first day with Mark Philippon, who's one of the most amazing charismatic guys in the world. And I sat there and watched him operate on these hips for 12 hours straight. And he let me close the portals. And I'm like, oh my God, this is the worst mistake I've ever made in my life. And, but Mark was such a, he was a real on the cutting edge and he was pushing the envelope. And it was a really amazing year to really sort of explore what the opportunities are in the field. And there's a lot of frustrations with it too, because it wasn't mainstream, and many cases it's still not mainstream. But it was one of those fields similar to what Dave Levine had said about foot and ankle. It's like nobody else is doing it, and shoulder arthroscopy was around at this point in its development 20 years ago, and the knee was like this 30 years ago. Maybe this is the next frontier for sports medicine. And I did also, because Mark would go away 1 week a month because he still had a practice down in Florida. So I would take that week and I'd operate with some of the other guys at UPMC. So I got to work with Jim Bradley and Chris Harner a little bit and Freddie Fu. And so I got exposed to other people's techniques. So it was actually, I'm like, if this whole hip thing doesn't work out, I got to make sure I still remember how to do an ACL when I get back. And when you're doing, so you come back as a hip arthroscopist, talk about a specialty where there's nobody that likes you. All right. So I'm going to be the sports medicine guy that's doing hip. The sports guys are like, what? Like sports isn't that. Hip's not a sports joint. You either have arthritis or a groin pull. Like, what are you talking about?
Or trochanteric bursitis. That's it.
Yeah. Right. The arthroplasty service is like, Well, they're a little bit appreciative because they feel like anybody you touch with a scope, they're eventually going to have to replace their hip because you're going to screw it up so bad. And even the people like Professor Gons, who are really forging the field forward with their better understanding the mechanics of femoroacetabular impingement, dysplasia, and really gave a lot of the groundwork upon which we were able to build the field of hip arthroscopy. They thought hip arthroscopy was the tool of the devil. So, why would you go to a peep show and, it's keyhole surgery and all that?
It's interesting because most surgeons who then go into a career, when they look back, they think, I did this job and it turned out I really enjoyed this job. I had tremendous aptitude for this particular surgery, or I found this trainer particularly inspiring, or it was all my mates were doing it, so I did it as well. But you kind of got into hip arthroscopy because it was the thing that nobody else was doing. It initially didn't seem particularly appealing, and actually grew on you subsequently, and no one was really supportive of you doing it.
But, there must have been a point where I was just thinking, as you say, it's still viewed with suspicion, right? Some unkind people, not us, say that it's an operation looking for an indication. And the challenge you've got, as you mentioned, is that hip replacement actually works pretty well of all the things that we have. But there must have been a point where you walk out the second hip arthroscopy HS and you go, I'm never doing this. And you want to do it. And there must have been a moment where you thought, shit, I can see this. I can do something. I can make a difference. When was that? Was that on fellowship?
Well, on fellowship, I realized I can technically do it.
Right.
Because technically it was more challenging than a lot of the other stuff that I had done in sports. I wasn't 100% sure I was helping anybody because there was still, I didn't have enough follow-up. It was really in practice when I started seeing patients back. And look, the success rate of hip arthroscopies early in my career was much lower. When I started, I was doing everything. I was taking trauma call, I was doing total hips, total knees, multi-ligament knees, shoulder replacements, shoulder fractures, bread and butter sports, and hip arthroscopy. When I would see patients back, I would be like, every patient I was like happy to see, except for the hip arthroscopy ones. Because I'm like, what am I walking into? Like, are they going to love me or hate me? So I think that the challenging aspects of hip arthroscopy, it's not just the technical component of it, but the nuances of the indication are very, very subtle. And how do you predict who's going to benefit from it? Now there's, I think femoroacetabular impingement as a pain generator in athletes, for me, has become one of those things. I know that I can help that patient. And I know with a high degree of predictability that those patients will do well. But there's a lot of subtle ones that you still wonder, like, should you push the envelope? Is hip instability? Is there a little bit too much cartilage wear? Is any cartilage wear too much? So I think what I've evolved to is you can help a lot of people with this technique for the appropriate indication, but there's a lot of landmines. And as we've seen the numbers of hip arthroscopy across the country and the world explode, when I was doing it in 2003, I think there were about 5,000 hip arthroscopies done in the U.S. a year. Now there are 200,000 in the U.S. and double that worldwide. It's just like that's a pretty significant growth in the numbers. And I think the challenge that we see is that because there are all these landmines and traps, the poorer outcomes, we're seeing them more often than we think is appropriate for certain procedures. But I think there's definitely a role for it. And I think that you can really help a lot of people, but there's a lot of challenges with it.
So who's the exemplar patient, the ideal, perfect patient in your practice for a hip arthroscopy? Who's the person you go, this is going to be a cracker, this patient's going to love me?
18 to 25, male, with an anterior cam lesion, normal femoral version, no dysplasia, perfect coverage, and motivated to get back with no cartilage wear, and unable to play at the level that he wants because of his hip pain.
Right. And what's causing his hip pain? Is it a labral tear?
There's the cam impingement.
Well, it's the cam. Yeah, it's the compression of the labrum from the.
Right.
I stopped using the word labral tear, the term labral tear, but with the cam morphology and the skating motion, there's this constant flexion and rotation where the bump keeps on banging up against the labrum, and the whole anterior superior aspect of the joint is just like bright red and inflamed. They can't sit, they can't skate. And you go and you clear out the inflammation, stabilize the labrum, get rid of their impingement morphology on the neck of the femur. You increase their rotation by 25 degrees, and they love you. They go back and they play. I have players in the NHL right now who I operated on when they were in high school and they were about ready to quit playing hockey. That's the ideal one.
So you think, and in that setting, it's a curative procedure, or at least that's how you're going into it.
Well, cure. I don't know if you're talking cure, meaning that they're never going to have progressive damage to their joint. I think
Yeah, no,
that's a bit of a stretch.
Yeah, I guess that is what I'm saying. I'm just wondering, because I always mocking Kash about, when you fix all these ACLs in young people, are you preventing knee arthritis in the future? And I guess it's the same question here, or do we just don't know yet?
Well, I think we know for the ACL that we're not.
Easy.
I was actually just talking to one of the senior surgeons, Dr. Wickwich, yesterday.
Yeah.
He said, I said, what are you doing? He said, I'm doing a total knee. I said, that's great. I said, he goes, yeah, I did his ACL 25 years ago. That's a pretty good run at 25 years of it. Look, I think the question for hip impingement has not been answered the same way as it has been for hip dysplasia. We do know that there's a mechanical etiology for osteoarthritis, but there's other factors as well. The two types of mechanical factors that we think about in broad terms for the hip, why people develop hip arthritis, are hip instability, dysplasia, structural dysplasia, maybe collagen laxity instability, hypermobility syndromes, and hip impingement. And I think there's data that, again, much of this data came from Switzerland, where there was a significant reduction in production of the progression of osteoarthritis in patients who had treated dysplasia with a periacetabular osteotomy at 20 years than those who didn't. If your center edge angle is less than 16 degrees, you've got about a 95% chance of having arthritis by the age of 60. If you get a PAO before you have arthritis, you still have your natural hip at the age of 60, 80% of the time. So there's good data. We don't have that data in hip impingement. And I'll tell you a story about when I was about 2 years in practice. One of my international colleagues who I'd become close friends with was Michael Leunig. He currently operates at the Schultheis Clinic in Zurich, and he is Reinhold Gans's son-in-law. So he was a resident with Professor Gans, and he married Professor Gans' daughter. And there's a whole bunch of questions about whether that was smart or not that he's raised, but it worked out for him. And so he calls me up and he says, Brian, can you come to Zurich? We're doing the annual hip preservation course, and I'd like to give you a talk. I said, all right, I'd love to give you a talk. So he sends me the program in German. I couldn't read it. I did notice that my talk was 2 hours long. So I'm the dumb American who only speaks English. So could you do me a favor and translate it for me? So he sends it back, and the program that I was going to be involved in was preceding my 2-hour talk was Professor Reinhold Gans doing a live surgical hip dislocation, broadcast to the entire audience, followed by Professor Bryan Kelly doing a live hip arthroscopy, followed by a live debate between Professor Gans and Bryan Kelly in German on the technical limitations of hip arthroscopy and the management of femoroacetal impingement. I'm like, what are you crazy? Like, that sounds like a setup for failure. Like,
that's a stitch up.
And so
that is a stitch
I ended up doing it anyway, even though I remember going to Dr. Warren, the guy who hired me. I said, would you think this is a good idea? He said,
no.
Looks like the worst idea in your life. Like do it on a cadaver, but don't go, you're setting yourself up for failure. I said, I have so much confidence in my surgical skill. I can do it in Switzerland. The surgery ended up going fine. And I'm not sure what happened in the debate. There was a lot of laughter after every time that Professor Gans said something. I think it was at my expense. But at dinner, Professor Gans came up to me and said, look, that was, this is the first time I saw hip arthroscopy done in a way that makes me feel like it's the future. And I'm like, wow, this is great. Professor Gons thinks hip arthrosis is the future. And later in the evening, um, we had a few beers, and one of my colleagues, Dean Lorch, had come with me, and it was me, Dean, and Professor Gons. And Dean looks at Professor Gons and says, Reinhold, you really think this BS is true? Like, this doesn't work, does it? I'm like, you can't say that to Professor Gons. He just complimented me. And Professor Gons answered, I doubt myself more and more every day. I'm like, what is going on? Like, so even the guy who invented it was questioning whether it was real. So, I mean, I think the answer as to whether hip arthroscopy for that patient, that 18 to 25-year-old hockey player, is curative, I think it's still unanswered.
Yeah.
I will say that it is predictable in alleviating symptoms and allowing people to get back to a high level of function.
Yeah, got it. I know this sounds like a stupid question, but just answer it on the basis that, just on face value. Do you get, are CAMs 100% associated with arthritis? Do you ever get like an 80 or a 90-year-old with an obvious femoral neck bump, but no hip arthritis?
Yeah, absolutely. It's not 100% associated.
So it's not an inevitability.
Yeah, one of the arguments against femoroacetabular impingement by the arthroplasty surgeons, they'll come in and they say, look, I've got a guy who's got arthritis in his right hip, and had a bump, and he's got the same bump on his left hip, and his left hip looks fine. You're telling me that wouldn't have happened if you took the bump down? So yeah, I think there's still a lot of unanswered questions, and I think that there are, I think arthritis is multifactorial. I think what I think is that I don't ever talk to a patient about doing this to prevent arthritis.
Right.
And in fact, patients come in all the time and they say, look, I got this labral tear. It totally doesn't hurt at all, but I don't want to get a hip replacement in 40 years. So can you operate on me? I'm like, are you crazy? No, I'm not operating on you for that.
Okay.
And the more challenging situation that isn't infrequent, where people will have a symptomatic hip on one side and totally asymptomatic on the opposite side, but they have the same exact mechanics. And they'll say, well, after you fix the side that they're symptomatic on there, they'll say, well, should we do the other side? Because I don't want to develop arthritis. And I'll say, well, I don't think we're to the point where we're operating on asymptomatic hips to change the natural history of a disease that we don't completely understand.
Yeah.
So I think, but these are what you're talking about are all of the landmines that exist, because it's tempting.
Yeah.
Oh yeah, I'll do two of them instead of one.
Yeah. Yeah.
But but the reason why knees are better than hips is because I can tell you categorically, I've never done a knee replacement on a patient who's had a previous meniscus repair, right? So it clearly works at preventing arthritis. But it's interesting. You say it doesn't prevent it, but you were instrumental in setting up the Center for Hip Preservation. And I must say that, just want to say, by the by, that's some genius marketing there, Don't amputate the hip, preserve it. But that is suggesting that you can preserve their hips and there is some longevity to it. What was the thinking behind setting the center up?
I think for me, it was, so just so you know, from a marketing perspective, when we actually had this sign up. It was called Center for Hip Pain and Preservation. And Michael Leunig was visiting from Switzerland. He looked at this. He goes, you have the word pain right over the door. You got to take that off. So we took off pain and just put hip preservation. The field of hip preservation sort of, I think, is a surrogate for somebody who doesn't have arthritis that has hip pain. Can you figure it out? And I think what I realized is that there's lots of different reasons why people have hip pain. And could we create a comprehensive center where anybody with hip pain that nobody in our institution who does joint replacements would have the desire to see could come, and we could come up with some sort of solution for them. And so it for me was important to have open hip surgeons. So we recruited Dr. Ernie Sink from Colorado at the time, who's one of the preeminent periacetabular osteotomy surgeons, and
for sure
also does other hip preservation procedures open. We had a non-operative person, physiatrist, because there's a lot of overlap with hip pain and back pain. Lots of these don't need any surgery at all. Physical therapy, and an arthroplasty surgeon who wanted to specialize in young people who needed hip replacements. So what I wanted, the concept of the center was not so much about preserving the hip. It was about getting a comprehensive group of people together who can approach it the right way. This was from different perspectives. So Bill Garrett was giving a talk at the NFL Physician Society meeting one year, and Bill Garrett was passed away a couple of years ago. Was at Duke when I was a medical student, and so I knew him pretty well. He was a sports medicine surgeon. He was instrumental in sort of figuring out how to do ACLs, and he was giving a talk on something about hip pain. Oh, he was giving it on sports hernias because he'd worked with Bill Myers, who's taking care of the USA soccer team. You notice a lot of these soccer players, these hip and groin problems. So he gave this talk and said this patient had hip and groin pain. So he went to the general surgeon, said you have a hernia. He went to the the core muscle injury surgeon. They said you had a sports hernia, you need a core muscle repair. Went to the orthopedic surgeon who specialized in hip arthroscopy. He said you need a hip scope. And then he went to the Switzerland. He went to the open surgeon. Said you need a surgical hip dislocation plus a femoral osteotomy and a PAO. And then he went to the orthoplastic surgeon and said, you just have early arthritis. Come back here whenever it's bad enough. I'll give you a hip replacement. And so he goes, the moral of the story is, don't go to the barber if you don't need a haircut, because whoever you go to is going to do what they think is wrong with you. Right? They're going to use the tool that they have to fix it. And so my feeling about the hip preservation or the Center for Hip Preservation was, let's get everybody together so that the hip arthroscopist is not operating on dysplastic patients, and the open hip surgeon isn't doing surgical hip dislocations on somebody that can be addressed appropriately with an arthroscopic procedure. And we have a understanding of what the core is. If we think this isn't in the hip joint at all, should we be looking for core injuries? And we kind of know that back pain can mimic hip pain sometimes, and we have somebody who can really sort it out. So for me, it was more about a comprehensive approach to a complicated area to try to increase the likelihood that we're going to come up with a treatment plan that's going to have a good outcome for the patient.
Yeah, I thought it was an excellent idea. Danielle showed me around there in like 2014, and I just was amazed by the setup, by the concept. It was quite alien, you know. It was basically arthroplasty or nothing at that point.
Yeah. What was it like being those early days where, cause a lot of early surgery is held back by the level of instrumentation, isn't it? As instruments become more bespoke, more aligned to the particular nuances of that operation, the actual surgery gets a great deal easier. Were you involved in developing new instruments and new techniques? I mean, you must have said, what I need is a thing that curves a little bit and does a little bit and looks a little bit left and looks a little bit right. How involved in that did you get?
So that was one of the first things. One of my close friends from medical school, John Savarese, we were applying for residency at the same time. We ended up both going to HSS. We were roommates together our intern year. And the second year, our second year at HSS is not great. You're like, at least it wasn't 25 years ago. It's probably great for them now. And he's like, this is terrible. Like, I cannot see myself doing this. You're covering the Queens ER and the Bronx ER, and you're just getting hammered. So he quits residency and goes to business school in Stanford. And then ends up working as the healthcare specialist and device specialist for a private equity capital group called Montreux. And we kept in touch the whole time. And he said, well, if you ever have any ideas that you want to do something together, I'll do it with you. Well, I've got the money for it. So when I was in Pittsburgh, and we're using straight knee scopes, instrumentation into the hip joint, and everything's like we would break like 5 scopes a day. We'd have like,
just trying to look around the corner.
I used to call it the bouquet. The bouquet of disposables at the end of a case was like we'd break like 15 shavers, and then Mark would like put them up in like a bouquet. He's like proud of how many broken in one day. And there's got to be a better way. So we started a company called Pivot Medical, and got some capital backing from John's group, and then one other group called Fraser Capital. and we developed a whole line of hip arthroscopy instrumentation that subsequently got sold to Stryker. I wasn't a very good businessman at the time because I hadn't learned about the word dilution, which is every time somebody gives you money, whatever shares you owned at the beginning gets diluted. So my percentage ownership in the company that I started ended up being like 0.01% at the end. And I'd also written away, and they're like, you can either have equity or royalty. Which one do you want? I'm like, I don't know. Can I have both? They're like, no, you can't have both. You need to choose. I said, well, I'll take the equity. I own 17% of the company. And so I wrote off all my royalty payments and had equity that by the time they sold, it was like diluted down to nothing. But so that part was frustrating. But I still use the instruments. I use the instruments that we invented to this day. And so it was really kind of cool to like have an idea and say, well, this is the technical problem we're trying to solve, speak with some engineers, build something, and then you're using in the OR. They open up the box. And so
that's really cool.
But the pivot sale to Stryker was quite a monumental sale at the time, wasn't it? It was big numbers, if I recall. It made news.
I think it was about 100, maybe 110.
Million
pounds.
Yeah, slightly different order of magnitude.
Remember 0.01%.
Yeah,
didn't go a long way. What was hard about the sale was that nobody knew where the field was going. So like, why would we spend money on hip arthroscopy equipment when we don't know where the field's going? So it was interesting because I would go on these calls where we're trying to get people to either give money to support the development, or later go to companies that wanted to buy it. In the first half of the meeting, you talk about why hip arthroscopy is important. Like, because nobody's like, I never heard of it. Like, what's impingement, FAI, dysplasia? Who cares? Like, why don't you just give them a hip replacement? So part of the difficulty in making the sale was exactly what we've been talking about. Is like nobody really appreciated where the field was or where it could potentially go.
Yeah.
Well, Pete's designed some pelvis plates, right, which are going to make a lot of money.
Selling like hot cookies.
Like hot cookies. So, if you're going to advise someone in the future, would you advise equity or royalties now? I mean, I'm curious.
Yeah, what's the
Well,
answer?
I recently learned you can have both, so I'd say get both.
Get both.
Okay.
Well, you know me, I value loyalty over royalties. You're Mr. Hip Arthroscopy. The thing's interesting is, so Russell Warren is widely considered one of the fathers of the noble art of orthopedic sports medicine. And I mean this with the greatest respect. It's almost like there's like a Russell Warren playbook, and it's almost, and clearly he's mentored you and he's coached you, because he wrote about the blood supply of the meniscus, then you talked about the blood supply of the labrum, and it's interesting seeing some of that. And so was that intentional or pre-planned? Was that from his mentoring? I'm just curious as to, because you've done a lot of research, how did that develop?
Yeah, I would say for sure Russ Warren has been an incredible mentor for me. When I started my practice, my main office where I was working was at New York Presbyterian Hospital, which is our academic affiliated hospital where all the trauma goes. And my feeling at the beginning was, I want to have as many different ways to protect me from failing in New York City as I can. So I'm going to take trauma call. I'm going to be doing hip arthroscopy, which nobody does. I'm going to do comprehensive sports. I'm going to be working with a team. So I was trying to do all these things. So one of them was working at New York Presbyterian, where I saw a bunch of multi-ligament knees and, knee sprains that ended up being ACLs and shoulder dislocations that needed surgery. But one day a week, I would see patients at New York HSS, and I had an office that I shared with Dr. Warren. I wouldn't say I shared the office. I had a very small desk in the corner of his office, in the same location that he was. So I would stop by that office anytime I knew that he was going to be there. And it was, I'd bring some x-rays. I'd be like, hey, Dr. Warren, can I show you this x-ray and let me know what you think? And so having close proximity to him and being able to bounce ideas off of him was a huge advantage for me. I remember seeing patients with him on a Friday, and I had this woman who came in with complete atrophy of her gluteus medius and minimus, huge Trendelenburg gait, couldn't walk, had a prior I don't know, IT band release, big hole in our IT band. And I said, it kind of reminds me of like a atrophy of the supraspinatus and infraspinatus, and you do a lat transfer for it. So I go to Russ, I go to Dr. Warren, I said, you think there's like a transfer you could do to provide, that those muscles that are supposed to be doing what they're doing aren't working? Like, what, you think I should transfer something? He goes, yeah, just transfer the glute max, bring it up and bring it over. There's got to be something in the literature. Why don't you read about it? There's nothing in the literature except for the white side procedure, which was developed for people with total joints that had abductor dysfunction. And so I actually sat down with him and said, so he helped me think through what type of transfer could you do that was similar to what you were trying to accomplish in the shoulder. I remember one day I came back, and it was probably a bad clinic day where patients weren't doing as well. And I said, Dr. Warren, you were involved in sort of the progression and understanding of arthroscopic shoulder surgery. You've invented it. He goes, I said, did you ever make any mistakes? Like you thought something was going to work and then it didn't? And then how'd you feel about that? He goes, did I make mistakes? Yeah. When we first started seeing symptomatic labral tears in the shoulder, we cut them out because it was the pain generator. We did that for about a year. Every single one of them dislocated. He said, did you feel bad about it? He said, no, I didn't feel bad about it. I just stopped doing it. And so he was helpful just sort of to help me think through some of the challenges of being in a field that you can't go to the book and read what the right thing is to do.
Yeah.
And being okay with it, because it can be very frustrating at times. It's frustrating to try to do something new. You can, for sure, you question yourself. You'd be like, is this, I could be doing things that are already figured out. And I think being around people who have been through that process gives you the courage to say it's okay to do it. It's okay to make some mistakes along the way. Just stick to some basic principles and ethics and morals, and make sure if something's not working, you change. But it can be challenging. It was very helpful to have somebody who'd been through it help sort of talk through some of those issues.
And certainly, by providing the literature, by doing the research on it, you're helping a whole generation of patients, right? A whole generation of surgeons, and that's how we develop and advance the specialty.
Exactly. Yep.
Yeah. So you were made Chief of Sport Medicine at HSS at a pretty early stage. Tell us about that.
Yeah, so that was, I guess, in like 2014 or so. We had started this Center for Hip Preservation, and early in, Tom Skolko was the Surgeon-In-Chief at the time, and I went to him and I said, would you consider turning this into a service, a real service line? And like this is kind of goes back to the culture of HSS. Like to be a service was like really important, because then you could have a chief of the service, and then you had the perception that you would be able to implement change. So he's like, yeah, I think it's a great idea, and he makes it a service. He does whatever, he signs whatever, and so we were a service line, hip preservation service, and so I was chief of it. I did that for about 5 years, and then there was a lot of sort of change that was occurring on the sports medicine service at the time, and I was asked to become transitioned to the new sports medicine chief. It was really challenging because I was in sort of this weird subspecialty sports medicine, and most of the things that people were arguing about was, is it a double bundle ACL, or is it is it a hamstring or a BTB, or do you need to do a lat J, or can you do it arthroscopically? And I know how to do all those things. I just don't do them anymore. At that point, I had kind of transitioned to all hip. I do think that it gave me a unique perspective to look at things a little bit more objectively. So I don't have any personal skin in the game whether ACL repair works or not. But I think we have to look at it objectively. If we're gonna start doing that here and say we do it here, are we following it? Are we making sure that patients are doing okay? And so I think it was in some ways a challenge, but other ways a help to be sort of on the periphery in sports. And at the same time that I became chief of sports, I also took over as the head team doctor for the New York Rangers, which is been an incredible experience. I've been doing that for the last 8 years, and that being a team doctor in the sports medicine service also helps a little bit just in terms of credibility and understanding some of the issues. But sports medicine, we have, we've got it's a big service. In many cases, it's bigger than most orthopedic departments at the time. We're up to 35 surgeons on the sports medicine service. We call it Sports Medicine Institute now. And they're all highly competitive, very, very talented, excellent surgeons who have sort of their own personal sense of what the right thing is to do. So how do you navigate that when you've got all these different people is challenging. But that's part of leadership, I think.
But it's interesting because you being a hip surgeon, as you say, the shoulders, his knees, all the other stuff, you're kind of like Switzerland, right? You're just a neutral observer in the middle. No one's going to be gunning for you. Yeah,
and that's why I was wondering, is it helpful, the fact that you're in a comparatively niche specialty with the knee guys all competing with each other and the shoulder guys all competing with each other? At least you can stand off that a little bit and be, as you say, more objective. Do you think that's why it's a good leadership position?
Yeah, I mean, I think there's some good things and bad things about it. I mean, I think at HSS, any leadership role here, it's very clear you have to be a respected surgeon.
Yeah.
And I think, like, if you're not a respected surgeon here, you'll get run out of town pretty quickly.
For sure.
So it definitely helps with the objectivity, but there's still some question, like, well, what exactly is this stuff? So how do people respect what you're doing if nobody else is doing it, or they don't understand it? So there may be a little bit of that. They're like, oh, he just does hip arthroscopy. You should come and see what I do. This is real surgery. I'm like, all right, well, why don't you try one of these? They're pretty hard. I think there's a balance, but I think the key, above and beyond, you have to be a respected surgeon. I think if you can maintain the respect of the surgeons from a surgical technical skill set level, and you can be a little bit Switzerland at the same time, I think that's a good combination.
Yeah. It's interesting because one of the things that generally happens, I don't know about over there in the UK, as you get into more senior leadership positions, most people give up the surgical side. And so you're right, you can lose that credibility. And without credibility, then what you say doesn't carry a great deal of weight.
Yeah, that's absolutely the case, particularly in the UK, is that, as you move up. I mean, is that something you found moving up to Surgeon-In-Chief, that you've had to give up clinical sessions?
So I've cut my volume down for sure. And, the role of Surgeon-In-Chief at HSS has evolved over the last 160 years. And the thing that's evolved the most is the size of the institution. Even when Dr. Warren was Surgeon-In-Chief when I first started, we had one hospital with probably a third the number of operating rooms and half the number of patients inpatient, but they'd stay a lot longer. So now we've got a lot more, but they're running through on 24 hours. Now we have this big hospital, got 140 surgeons. We're doing 36,000 surgeries a year, and we have 15 satellites in the tri-state area in Florida. It becomes a management issue, so it definitely has changed. So the amount of administrative time that you have and the amount of sort of brush fires that you encounter, and sometimes forest fires that you encounter, are higher. So I think it's harder to do it as a 1 day a week type thing, which I think was possible to do, 20 years ago. And so now this is a full-time job, and so is your clinical practice. So you have basically 2 full-time jobs. So you just figure out, how do you compress 2 full-time jobs into a 7-day work week?
Yeah. Yeah.
And so, but I've decreased my volume. I'm probably now, about 50 or 60% of my surgical volume that I was in 2014 before I started taking on any leadership positions.
Yeah.
I know you just said a 7-day work week. Did you mean 5 days or did you mean 7?
I meant you got to squeeze everything out that you can.
Yeah, no, I'm with you. Yeah.
Squeeze all the juice.
Yeah, no, it's a city that never sleeps.
Yeah. And what is it like? We're not expecting to name names or anything like that. We're not after scandal, but just what is it like looking after and managing the expectations of and sorting out the problems of all of these really, really high-functioning surgeons?
So I think, I started and look, I think leadership, you said we read books, and I have so many self-help books at my house right now. Every day I come home, my wife will be like, I think there's an Amazon drop-off. You get another self-help book. You think you're going to read about this? It's just experience, and you sort of evolve over time. And there's some principles you can read about, and you can talk to people. But one of the things that I've realized is the surgeon mentality is that there's a start and an end to things. You start a case and you end it.
Yeah.
You have a patient, you fix them, you don't see them again. And what I've realized about the leadership stuff is there's defined start points. Oh, I just heard about this problem, but the endpoints aren't as defined. And so, you guys are probably like me. You like to, check the last thing off the list before you're done for the day.
Yeah.
And you have to get comfortable with, I'm not checking that off the list. There's still like these other things that you have to figure out. So I think part of it is your approach. I think the second thing is your ability to not take things personally and to really step back and really try to look at things as objectively as possible. Look, I've got a really close friend who thinks X is the right thing. I have a new really close friend who thinks Y is the right thing. And if we decide on X or Y, one of my close friends is not going to like me anymore.
Yeah.
Like you can't think that way. You have to look at it very objectively and, try to get people to see what the other person's perspective is. And look, if you piss people off, then you do, as long as you're doing it for the right reasons. I remember Tom Skolka, when I started, who had been Surgeon-In-Chief when I started, said to me, you'll know when you're ready to stop when you have more people that hate you than like you. I'm like, well, that's a really uplifting thing to think about. Thanks for the motivational speech. So I think those help. I think the other thing for me that I've realized is the more you can engage other doctors into sort of leadership positions and help you think through things, then all of a sudden it's not like me against everybody.
Yeah.
You got a team of people that you're thinking about things with, and you listen to what they say and get different perspective. And even if you don't agree with them, having a seat at the table and being involved in the decisions really goes a long way, and it changes people's approach to things. The worst thing for the culture of any institution for me is, from my perspective, is if the group that you're leading doesn't feel empowered, they don't trust the decisions that are being made, and there's not adequate communication or transparency about things. And you just say, no, I swear this is the right thing. I guarantee it. And even if it is, if they haven't been involved or there hasn't been adequate transparency, there's a level of paranoia and distrust that exists in any institution that is impossible to overcome. So a lot of it is like, get people involved and get them to participate. And you can complain a lot. You complain, well, what's your solution? Help me figure it out. And try to engage them has been helpful. Well, look, I'd say the ability and the privilege to be in this position and try to do, my approach is I'm the advocate for the medical staff. We have an amazing institution that provides the resources and the infrastructure for people to have the best environment where they can work and become experts in their field or their profession. And everything that I look at is, all right, from the perspective of medical staff, what can be done to make sure that clinical care is the highest, that we're focusing on academics, research, education, teaching, and innovation, and that we're doing everything that we can to make sure that all of the doctors feel that they can succeed here better than anywhere else, professionally, academically, and economically. And so, I mean, those are sort of, and you just have to have sort of general principles, but it can be really challenging.
Yeah. What about some of the guys who are older than you? You're going to the job pretty young. What about some of the people, because you've been there such a long time, there must be people working there who are considerably older than you in years and seniority, and they perhaps do they sometimes struggle with you being a bit of a whippersnapper? Someone who they they knew you as a resident. I knew he was a resident, and he was a
couldn't do a hip scope, and now you're kind of and now they have to listen to you, right? People have trained you, perhaps.
Is that a problem, or is it not?
It's probably more of a problem for me than for them.
Right.
To be honest with you. Like, I feel like I can't tell Dr. Warren. I'm gonna. So who's gonna tell Dr. Warren you're gonna pull some OR time from him? I'm like, not me. Let someone else do that. Why don't you do that? And I'm trying to get you more involved. Why don't you try that one yourself? But one of the things that I did right off the bat is I put together a senior advisory committee. I took some of the senior people here, and I said, look, I want to meet with you guys, once every 2 months. We'll go out to dinner, and I'd love to use you guys. I'd like to just sort of tell you what's going on and hear your perspective on things. And it's the same concept. I think it's a problem for them if they feel like nobody's listening to them.
Yeah.
And so asking them for their advice and bouncing ideas off them and hear what they have to say. And then, they got a lot of good ideas. Oh, I didn't think of that. We should really try that. And you do it, and you're like, I just tried your idea. It worked well. Thanks. I think you can engage them in ways that makes them feel like they're, not only a part of it, but they're helping me in a way that I need the help, and they can provide it because they have this institutional knowledge and experience that a lot of people don't have.
I'm curious about your MBA because at what stage did you do the MBA?
I did it in 2017.
Right, and was that with an eye?
2 years.
So that's relatively recently, right? And some people do it as part of a MD MBA program. And was that with a view to that you knew that the Surgeon-in-Chief was a step that you'd be earmarked for, and it was to prepare you for that?
Well, so I think you're getting the sense that a lot of the decisions that I make in my life are not really well thought out, starting with my middle name being Talmadge, hammer thrower, music major, psychology major, working in a mental health system. I'll just go to medical school.
Yeah.
I think I'll try this hip arthroscopy thing for my whole field. I'll tell you, the reason it was not because I'm like, I need this. There were two reasons that I thought about doing it. One was because I was running such a bad private practice. Like we're basically, you run your own practice. And I was like, my expenses are terrible. Like my bookkeeper was stealing money from me, and I didn't have control over. Like I didn't take any control. So I thought, I need to just like be better educated about this stuff. And the second was that I as the service chief for sports, I thought there were things that I could learn about leading high-performing individuals. So I thought leadership in general was something that was interesting to me. So it was in the back of my mind. And so I remember. So this was in 2017. So I was traveling with the New York Rangers in the playoffs, and we were playing Ottawa. And I had to travel. It was like 2 games home, 2 games away, 1 game home, 1 game away. And so I was on the 2-game away thing, which was about 4 days. And I was sitting in my hotel room, feeling like my whole life was going like just wasting away. So I called up Todd Albert and I said, who was the Surgeon-in-Chief at the time? I said, what should I be doing? I'm like sitting here in a hotel room in Ottawa, which is the worst. Never seen a city like this. It looks like this is where the aliens would definitely land here because nobody would see them. And so I said, should I be doing more in academic society? Should I be doing this or that? And he goes, no, you should get your MBA. And I'm like, all right, sounds better than some of the other stuff. So I literally looked up at the MBA programs in New York City. There's NYU and there was Columbia. Columbia required that you took your GMATs and NYU didn't. So I applied to NYU.
NYU it is. Yeah.
NYU it is, yeah. And it's in a cool part of the city. I thought it'd be fun. And it's a very well-respected executive MBA program. So I ended up sending in my application, thought there was no way this was going to work. I get a call for an interview, and I'm like, never be able to make an interview. My schedule's too busy. They said do a phone interview. So I do a phone interview when we're back in Ottawa in the locker room before Game 7 of the second round of the playoffs. I'm like, Rammer, he's a trainer. I said, Rammer, I got to take this phone call. Like, inject a little Toradol, do your MBA interview, come back and inject a little more Toradol. And so I'm talking to this. I do an interview in the bathroom stall of the locker room in Ottawa, and we had a great conversation. And she's like, all right, I think that's all we need. I'm like, that's all you need? Like, that's it. I'm literally, that can't be a real interview. And so then I got accepted. I realize now that it's not that hard to get into the executive MBA program. I was really impressed at first. So I will tell you that the 2 years that I did it, I loved it. It was such an eye-opening experience. It was one of the best educational experience for me that I've ever had, because I was just really doing it for myself. And you would go, it was every Friday, Saturday, every other week for 2 years. And so, I just switched some things around with my clinic schedule, and but you go down there, you put a hat on and a backpack and wear some jeans, and you're totally anonymous. And you sit in the back of the classroom and you just like soak up this knowledge. And I didn't care whether, I was just literally doing it for me. And it was really, really gave me some perspectives I didn't have. And I think in terms of the in leadership roles, particularly at an executive level, I don't think it actually gave me some massive insight into how to go in and really look at the books and really say, oh, here's what we need to do. We need to change it from this to that.
Yeah.
But it gives you a vocabulary so that when you're seeing things that don't make sense, you're not afraid to say, well, could you just explain that a little bit more? And you're not afraid to do it. And they think that you're MBA and you actually might know something. So then they have to go in and give you a little more detail. So I think it gives you, it's like the power of knowledge, but it's really not that much knowledge. But it gives you a different perspective and a different lens to think about things.
But MBA, it's hard yakka. It's hard work, isn't it? I've had a number of colleagues, I've not done it myself, but a number of colleagues who've done MBAs, gone off to do them, and they drop out in the first year or first 6 months because of the workload. They're doing essays, assignments, and they just can't handle the workload. Maybe it's because they were going in for the wrong reasons, or it just didn't suit them. But you said you loved it. How did you manage that workload? Or did it not feel like work?
It did. It felt like work. I mean, there's some foundational courses like, accounting, microeconomics, macroeconomics, corporate finance, and, and it's like a lot of, I didn't even know how to push the buttons on the calculator. It's like, I couldn't even figure out how to turn it on and off. And going home and doing homework, it was like, and then having these, a lot of the MBA is group things where you've got like, you're going to pair up with 4 other people and you guys have to come up with a company idea and work on it together. And you're working with 4 people that you may like or not like, but you're like,
like the Apprentice.
We got to meet. Yeah. And then, yeah, exactly. It was definitely extra work, but I felt like it was fun. Like I felt guilty when I was there. I was having too much fun.
Right.
I remember before I was taking this corporate finance final exam. It was a 3-hour test. And everyone's like stressed out and they're like studying. And I'm like, do you see that thing that guy wrote on you got to put your phone away for the next 3 hours and nobody can contact me? Yeah. This is going to be the best 3 hours of my life. I have to talk to anybody for 3 hours.
I really want to do an MBA actually.
Do you?
I think when this OrthoHub thing goes tits up, I'll have the time. But my guilty pleasure is like when the wife's not looking, I'm under the sheets, I'm in the bathroom, I'm looking at MBA programs. So what are you doing? Nothing. I'm looking at porn. Don't ask. It's easy.
I would tell you, I would say, if you even think that you want to do it, you should definitely do it.
Yeah.
Because I just found to be real. Look, I think as surgeons, particularly busy surgeons, you miss out on like 99% of the world. Like I'm sitting there in this MBA class and they're talking about like why Blockbuster died. I'm like, when did Blockbuster go under? I was going to go rent a VCR tape tonight. I'm like, you miss out on all these things. Like Radio Shack doesn't exist anymore. Seriously, what happened to Radio Shack? And I think there's a whole different way of looking at the world, and it puts things in perspective about what we're doing. And then I think when it comes to healthcare, you look at what other industries have done. in terms of integrating digital and technology into their ecosystem, improving efficiencies. And we're still looking at X-rays on a X-ray board with a light box. And there's so many things like, if the banking industry is able to do this, it's the same problem. It's about maximizing efficiency, making sure the data is right, and like integrating artificial intelligence into decision making. I mean, there's so many things that we could do that have already been done in other industry. We just apply them to healthcare. We could really fix a lot of the problems that we deal with.
Yep.
Building on that business development that you talked about there, so the Cleveland Clinic have expanded to multiple sites in the US. They're in Abu Dhabi. They've just come in the UK now, in Her Majesty's London. Mayo Clinic are always looking to expand. HSS has a massive global reputation. It's ranked #1 for orthopedics. What are the plans for HSS's expansion beyond New York, beyond the US? Are there any?
I think expansion. I mean, here's, and this is one of the things we talk about all the time. Like, grow or die.
Yeah.
Well, then people are like, well, it's pretty good the way we are. Why do we need to grow? So we've grown massively over the last 20 years. We've grown to these 15 satellites, and we have some things we're doing in Florida. We've explored the UAE. We actually I went to London a few years back, looking at anything we can do in London. I think with the consolidation of healthcare that's currently occurring, at least in the U.S., is that massive hospital systems are buying hospitals, and we're going to buy 10 hospitals and own all these patient lives and employ all the doctors, and that's our solution to healthcare. But then it's such a mucky system; it's hard to navigate. And in New York City, 20 years ago, there were about 100 independent hospitals. In 2022, there's 5 hospital systems and 2 independent hospitals. One of them is HSS, and the other is Memorial Sloan Kettering. We're the only 2 hospitals that haven't been
Gobbled
merged into a hospital system. And I think one of the keys to our ability to maintain our relevance and our ability to do things a little bit more with more agility is maintaining your independence. And the only way you can maintain your independence is you got to expand. You have to do it in a way that doesn't compromise brand, and that's very challenging to do.
Yeah.
When I think about what made HSS special when I first got here, it was a boutique Upper East Side hospital. It was like a one of a kind. Everybody knew each other. It was much smaller. It was a great working environment. And I think what sort of my thought process is, what HSS has to do to expand is we need to become boutique at scale. We need to recreate that same high quality, high touch type of environment for patients, but do it in more locations. We'll expand market share. We'll have different revenue streams, and you have to penetrate different markets. Expansion, we've learned, isn't, and you say we have a massive reputation globally. We actually have a very specific reputation. Other orthopedic surgeons know who HSS is. I bet there's nobody, unless they've actually been to HSS, who's not an orthopedic surgeon, that's ever heard of HSS in London right now.
Yeah.
And we made this mistake when we expanded to Connecticut. It's 30 miles away. Everyone knows about HSS. But we're going to plop HSS down in Stamford, Connecticut, and we're going to run all the locals out of town. Well, there's lots of local relationships, and the referring doctors still send them to the local people. They're the ones they see in the grocery store on Sunday, and so the reputation is good from a surgeon-physician standpoint, but it doesn't really penetrate to the consumer or the patient. And so what we've realized that our expansion is really necessary to maintain our autonomy and ward off the enemy forces of hospital consolidation. But it can't be done on our reputation, and probably needs to do with partnerships with people who have the local penetration. And so that's kind of the way we were thinking about it.
Right. And do you ever see a time where HSS will be beyond orthopedics and involve other medical specialties?
I think one of the things, again, this debate about what's more efficient in healthcare, specialty hospitals or multi-specialty hospitals. I think specialty hospitals is a unique benefit to them. There's some challenges too. We've had, in the last year, we've had 3 different college teams that we take care of say, we actually need a multi-specialty hospital because it's great. We love the orthopedics, but we need a OBGYN person also. And we also need a cardiologist, and all you are is orthopedics. So there's something missing from a specialty hospital as well. Look, I think that we have a neurology department, we have a rheumatology department, we have pathology department, a radiology department, we have subspecialty medicine departments, we have psychiatrists, we have endocrinology. I mean, we have a few things, but they're all sort of built around musculoskeletal health.
Yeah.
Yeah.
You're not going to run your aortic valve replacement center at HSS.
Yeah.
I recently had a conversation with a neurosurgeon who said, well, because we want to bring neurosurgery in in partnership with the orthopedic spine surgeons, because most spine departments now are neuro and ortho.
Yeah.
And they work
Even ours
well
here.
together. And we for a long term, we never, neurosurgeons are terrible. They don't instrument the back. They don't know what they're doing. Well, now it's important. If you don't have a neurosurgeon in your spine program, people are going to go to the neurosurgeon and not stay here. So I was talking to this neurosurgeon. He's like, we'll bring our whole department there. And I'm not sure if we're ready for a brain surgery. Like, I don't want to do brain surgery at HSS.
Yeah.
And he's like, well, actually, like, this could be very synergistic. Like, what some of these neck surgeries, like, you go a little higher than the neck, you get into the brain. I think there's some things if you can make an argument how they complement what we're doing, which is a musculoskeletal hospital, I think we will grow those areas. But I don't think we'll ever be a multi-specialty hospital with departments that are taking care of sort of the diseases and all the different specialties.
Obviously, spent a lot of time over the years hanging out with sports teams. You talked about the working with the Rangers. What is the thrill with being a team doctor? What's the fun aspect to that? What's the buzz?
So I've been involved a lot in football for my first 12 years. I
With the Giants.
Helped out with the Giants, and now for coming up on 10 years, I've been with the Rangers. The hockey team for me is like such an amazing environment to be a team doctor. The football, I mean, and it's a little different. I was like an assistant team doc. I wasn't really in charge of making decisions. It's a much bigger team. It's a much bigger stage. But hockey is like you develop real relationships with the players where they trust you in order to help them, get through things. I mean, we've had some really incredible issues that have happened. In my first year, our goalie got hit in the neck with a puck and had a carotid artery dissection that I had to diagnose and would have changed his life if we didn't diagnose it. We had a guy who got hit in the head and had a subarachnoid hemorrhage. It's not necessarily about ACLs or hip impingement or shoulder instability.
Yeah,
it's about your opportunity to be like a
proper
primary
doctor,
sports medicine doctor, real doctor, real doctor. We had one of our guys got hit in the neck the other night. Took a slap shot right into the neck.
Jeez.
I'm like, oh my God.
I have to do a cricothyroidotomy.
The only thing I could think is, can you breathe? Can you talk? Raise your hand if you can talk. And
give me a biro.
And I'm like, well, I was thinking, and it was like right below his trachea. And I mean, it's one of the things in hockey, you worry about that. Puck into the trachea, crushes the airway, and you can't breathe, and you got to, you do crike on him. And I'm like, where's the knife? Like where's it? I'm checking on myself. I'm like, it's a soft spot right there. Right?
I can only do it on a sheep. I can't do it on a person.
Yeah, but these guys got thick necks, right? They got necks like tree trunks, haven't they? It's not.
Well, and the thing that made him feel like it was all right was because he trusted. If I said he's good, he's good.
Yeah.
And I think that's for me is like, it's a bit of a responsibility when there's bigger issues, but to be able to develop a relationship and trust with players and kind of help them through different things is like it's just a really fun experience. And the other thing is the relationship with the trainers. I mean, you develop a very special, unique relationship with the trainer, and if you have a good trainer doctor relationship, you know, but you're always on the same team. It's a really special, unique type of relationship.
You're also into UFC as well. Are you sports doctor for that, or just in as an enthusiast?
So I think the bio was a little off. So so we started the relationship.
Oh, strike me down now.
Probably about
The
7
bio
years
is
ago.
total shit. Sorry.
Nothing that you said was actually true, but I didn't interrupt. It sounded so good. I was like, wow,
Aren't I doing well?
I sounded confident, right? That's half the trick.
You did, and all I could think of, I'm going to have to give my marketing agent a pay raise. That was perfect. He said he was just going to write a short bio and give it to you guys, and that's what he came up with. No, so we started the relationship with the UFC about 7 years ago, and it's a really interesting relationship. When at the time there were a lot of people who said, "Do we really want to get involved in this? Like people trying to kill each other in an octagon? Like, aren't we supposed to be like helping people?"
It was considered violent and antisocial until quite recently, wasn't it? It wasn't on par with boxing.
Well, it is pretty.
Well, it was illegal. It was illegal in New York until UFC 205, which was when that's where the idea came, because we'd see these athletes, they come in and they'd have some problem, and they didn't realize they didn't have any sort of place to go.
Yeah.
They have a team doctor, or he called the cage doctor. He's called the cage doctor, Jeff Davidson, who's an amazing guy. He's an ER doctor in Las Vegas, and he travels to every event, and he's their real team doctor. We're the orthopedic consultants for them,
right? Okay.
And developed a good relationship with them. And now, you mentioned Bob Marks before. Bob Marks and Daphne Scott are the, official orthopedic consultants for them right now. But yeah, I started the relationship with them about 7 years ago, and tried to get some more people involved in it.
I know it's outside your expertise a bit, but just what's the deal with head injuries? Because I know that in American football, about 4 or 5 years ago, I think, or maybe I may have not got my times wrong there. There was a big hoo-ha about guys getting concussions and then having late sequelae of that, and the players sued there was a big class action lawsuit, and the same things happened in rugby in the UK. The British RFU has been sued by the players, or is being sued by the players, for these people who had repeated head injuries back in the day, which were kind of ignored, and people stayed on the pitch, and now they're having some early dementia symptoms. What's the deal with UFC and indeed boxing in that respect, where you're actually purposefully going for the head on a pretty much fight by fight basis? What's the is that going to end up going the same way, or do people sign disclaimers, or what's the deal?
That's a great question. It's one of those questions that I've been wondering for a long time. I mean, if you look at the class action lawsuit in the NFL, led to, we used to, in the NFL, line the guys up and give them Toradol shots. You'd have 25 guys get their vitamin T. And the only question would be right side or left side. And you just like load them up and inject them. As a result of that lawsuit, part of that lawsuit was that the indiscriminate use of non-steroidal anti-inflammatories right before a contact sport like that increased the risk for bleeding into the brain. And so as a result, we had to stop using really any medications in the training room. Now, the year that was decided, the first game of that season, there were 20 guys outside the training room asking for the Toradol injection.
It's like superstition by this point,
Oh,
right?
Yeah. I can't possibly play.
Helps, actually, I think it makes them feel better too. We said, well, we can't do it. The Players Association sued the NFL because they said we were using it too much. I'm like, you kidding me? Yeah. I won't sue. Just give me the Toradol injection. And so we stopped doing it. I think the sensitivity to head injuries became very public in the NFL. It's become very public in the NHL now.
Right.
And there's a lot of scrutiny to it. And there's independent neurological consultants who are the spotters, and you can get called down for a mandatory or discretionary evaluation where you have to take them out of the game. We had an incident that just came up in this season where our goalie fell down. He wasn't hurt. He like fell down, was trying to draw a penalty, and there was a mandatory removal from the game. It was an important game. Taking a goalie out with 3 minutes left in the third period, and then putting the warm-up guys like a guaranteed wage. Just why don't you just guys take the win? We'll take the loss. But they're like timing how long you're making sure you're doing it, and you have to like follow all the rules. So it has, and I think we all take it very serious, and the players do as well. They're like, I don't want to have this CTSD when I'm older and end up like Muhammad Ali. So your specific question is, what about the UFC?
Yeah.
I have no idea. I don't know, because we're just orthopedics. So, but it's really a good question. We do a course every year, and I think all of the sports doctors here are really sensitive to concussions. And it's like the old school, you just got your bell rung, go back in, toughen up, rub some dirt on it. Like that's not being a good doctor anymore. And so we do a course every year called a Professional Sports Medicine Conference, where we get all of the medical teams for all of the professional teams that we take care in the New York area. We bring the guys down from Boston who we have a close relationship. So the Patriots, the Red Sox, the Bruins. We get the Philadelphia docs, and we get some other people from across the country. It's a really interesting course. And the premise was, what's different about that injury in hockey than it is in baseball?
Yeah.
Because you treat them maybe a little bit differently. The management injuries are different. And so it's a really interesting course. We get all these teams together, all the medical teams together, and talk about things. So 2 years ago, I thought it'd be a great idea we have a keynote speaker that's a big draw. So I get Jeff Davidson come down, the cage doctor, and give us a talk. He gives us this talk. It's like
he must have seen some crazy shit.
Eyeballs hanging out of his head and his ears cut off. And we were thinking about calling a fight, but he was only unconscious for 2 minutes and he could still breathe. So we let him play and look around like, oh my God. And you see some of these, like, there's sensitive doctors and less sensitive doctors, but even the less sensitive ones are like, oh, this isn't medicine. This is like disgusting. And
like Mad Max or something.
So it's a very good question. You wonder. Now, when you talk to Dana White, he made the statement at one point that the UFC is the safest professional sport out there by this criteria. Nobody's ever died in the octagon, and people have died people have died in the ice rink. People have died in the NFL. People even died playing baseball.
Yeah.
Nobody's ever died in the octagon. I didn't do any fact checking on that, but that may or may not be true.
It seems like a bit of a reach.
But at the end of these fights, so I will go to some of these fights, and at the end of the fight, both athletes go back. You go back with Jeff, and they're literally separated by a curtain, and like they've just been going at each other for like 20 minutes, brutally. And now you're in like the eval area, which is like in the back room somewhere with a curtain between the two, and you're doing you got to do a full scan. You do a neuroscan, orthopedic scan, and what I found was that 25 to 50% of them at the completion of the scan, you just dumped them into the ambulance and they went straight to the ER. And so it's a rough sport.
Yeah.
And if they kick off in that eval area, it's up to you to hold them apart, right?
They're pretty tired by then.
You got a hammer. You're swinging on a.
Oh yeah.
No, that's fascinating. The thing I want to ask you was, I understand you're a fan of MMA. Is it true that you've got a wrestling ring at home and you invite fellows over and you fight them? Is this true? It can't be.
So first of all, I do that as a form of exercise for myself.
For sure.
It's not a wrestling ring. It's a dojo.
A dojo. Apologies.
Dojo.
No, a dojo is a spiritual place.
Built in sort of the Japanese, the authentic Japanese style.
With the screens around and everything.
Yeah.
Oh, okay.
It's authentic dojo.
Love it.
And I have invited people over to experience the dojo before, but it's not me fighting them.
Okay. Okay, it's more of a myth.
It's all for exercise. It's a great form of exercise.
Okay.
Yeah.
Now, I just saw a photo of you once somewhere of you and Bob Marks in a ring, and I was just wondering who would win out of you two. You'd fancy yourself against Bob, right?
I mean, he can hardly walk. He's got. After he gets his second hip replacement, we'll see. He'll be a little more mobile then.
Getting to wrap up the conversation, but just talking about your plans for the future. You've come to this like top end leadership position at quite a young age. Where does that? You were talking about endpoints earlier. And we have a start point and end point, and you've kind of got used to the idea that endpoints are less definite than the start point. What's the next stage for you? Will you carry on as Commander-in-Chief for a bit longer, or for an indefinite period, or do you have like a time when you'll say that's the end of that and I'm going to move on to the next thing, or how does it work?
Well, the position is 5 years, so I'm finishing my third year now.
Right.
I presume I have 2 more years, unless I get run out of town. I've looked at my here's what was always fascinating to me, and it's something I tell fellows when they start their practice. Our whole lives have always been done in sort of like 4 to 5 year increments.
Yeah.
You go to high school for 4 years and you're like done with that. Now I'm going to go to college. Go to college and like done with that. Now I'm going to go to medical school. Go to medical school, then I go to residency. Done with residency. And do a fellowship. Done with that. And then you become an orthopedic surgeon. You're like, holy smokes, I can do this for the next 30 years.
Yeah, that's right. Yeah.
So I've never done anything for more than 4 years ever in my entire life. And so I've looked at the 20 years I've been in practice as there've been phases. I think of them as phases. There's been like the beginning phase, which is just do as much surgery, do everything you can, just feel comfortable being a doctor. All right, I'm going to start to focus on the hip and build hip preservation, to a sports medicine phase, to a surgeon-in-chief phase. And it's actually worked out quite well in terms of the natural things that have happened in all of your educational training. So I would say, I think, this is typically a 5-year role with the option to renew it for a second 5 years if the board wants you to keep doing it and if you want to keep doing it. So I have a couple of years to figure out if I could do something for 10 years, because I haven't done anything for 10 years ever.
Yeah, but when you rack up each year and you rack up and every 5 at the end of those 5 year increments, you sort of move up to the next thing. Could you envisage a time where you just step back down into rank and file? You just become one of the guys who's back down to where you were like 5-10 years previously.
Yeah, because so far it's just been up and up and up, hasn't it, to a more and more seniority.
Yeah, I mean, I think of it. I think there's 2 ways to think about it. For sure, I want to be able to do that if that seems like the right thing to do. On the other hand, there's this book called The Second Mountain. A guy named David Brooks wrote it, and it talks about this whole idea of he calls it the moral perils of meritocratic society, where everybody's trying to like go up the ladder.
Yeah.
And when you achieve one thing, and this is where if you're an orthopedic surgeon, you're a victim to this. You're like, all right, I got that, and I want to do the next thing. And then when you got that, you got to do the next thing. And you feel like it's an achievement-oriented approach to things. And his argument is that you'll never be happy in life if that's the way you're going to think, because every time you achieve something, you immediately make that baseline. Now you got to achieve the next thing.
You just described Kash perfectly.
He's got a solution to it. It's called the second mountain, and that's the first mountain. And at some point in your life, you want to get off the first mountain, get onto the second mountain, and the second mountain has more to do with being a part of something that is more than just your own personal advancement, but you're part of a cause. And the best example, and the easiest example, is when you become a father. All of a sudden, you care about your kids. You should care about your kids more than you do about yourself. I mean, I think most people do. But then you talk about like leadership positions. You're like, you have to do it because you want to figure out a way to make something bigger than you could ever be better. and you're a part of that. And I guess my goal is to evolve into that second mountain approach where I feel like it's not about what my achievement is. It's more about being a part of something that's kind of cool and good to be a part of, and having a role in making it better. I think and he claims, the book claims you'll be happy once you do that. So I'll let you know.
Let's see what happens.
I'm going to order that book now. I'll get it on Amazon now.
It's another of those self-help books, isn't it? That your wife is like racking up on the bookshelf.
Yeah. Well, I'm reading one at the moment called 4,000 Weeks, because the average lifespan is 4,000 weeks. And when you look at it in that way, you think, gosh, the time is finite, right? And you really got to focus on what's important and what's real.
Yeah.
I think you're going to run for Congress next.
Yeah.
Brilliant. It's thank you very much for joining us. It's been fantastic having you.
Yeah.
I absolutely love chatting with you. I've learned a lot. So having you on has been a real honor. So thank you very much.
Yeah.
No, I appreciate it. No, it was fun, and it's I think it's cool that you guys are doing this.
We're just a couple of jokers who end up being in this position, but it is really fun chatting to people who have got interesting lives.
And the thing is, a lot of these questions aren't for interview purposes. I actually want to know what to do in my own life.
That's
and
right.
Kind of
Yeah,
help us.
Right. Yeah. I don't have to go and read all those books.
Yeah. Fantastic. Awesome.
Sorry, we've totally made you late for your next thing, haven't we? Sorry about that.
Thank you. Loved it. Thanks.
Cheers.
We'll see you guys.